And the topic that I will discuss, uh, so good day. The topic that I will discuss to you today is bias in research. And these are the learning objectives for this session, that at the end you will be able to define bias in research, and then you'll be able to describe the different types of research bias and then understand the ways to avoid and prevent bias from occurring. You see, in all research that we do, we want normally to generalize our results from samples to the
Recording
target
in progress.
population. And that actually is external validity when we generalize results from samples to population. But we can only generalize results if our study is, to begin with, internally valid, meaning there are no inherent biases or even accidental biases that we have in that study. And minimization, if not elimination, of these biases will make our study internally valid, that will lead us later on to externally validate our study. And if our study aims, for example, to determine the relationship between an independent variable and a dependent variable, between an exposure and an outcome, between a risk factor and a disease, for example, looking into the relationship between exposure to noise and cardiovascular disease, major threats to the validity of such a study can arise. And these threats should always be considered as alternative explanations in the interpretation of the results. Meaning, if we find, for example, a relationship between the independent variable and the dependent variable, these major threats can be considered as alternative explanation. The reason is because there is bias in this particular aspect of the study. And two error factors constitute these major threats of a study: the systematic bias, or what the systematic error, I should say, or what we call bias, and the chance error or random error that is due to sampling variability. Well, between these two errors, the most problematic, of course, will be the systematic error, or what we call bias, and that which we will emphasize in this lecture today. The chance error or the random error is not really a problem that's inherent in all research. We will always have a random error. Okay, so first we talk of systematic error, or what we call bias. And that is defined as any trend in the collection, analysis, interpretation, even on the publication or review of data that can lead to conclusions that are systematically different from the truth. And it can also be defined as a systematic distortion of the association between a determinant and an outcome that can be due to a deficiency in the study design. Now, conclusions about the results of such a study, when there are bias in our study, may lead to either underestimation or overestimation of the relationship in the determination of the relationship in question. And so we have these types of bias, types of systematic error, which we said is called bias. This bias can arise due to a poor or error in the measurement, and we call that the information bias, or a bias getting a sample that is unrepresentative of the target population. We call it the selection bias, and the effects of other determinants in the association of interest. We look at an association between two variables, and there are other determinants that can affect that relationship. We call it confounding. So we will discuss each of these types of bias one by one. First, we discuss information bias. That is a prejudice or a deviation from the truth about identification of data of variables in their measurement or in their classification. When we classify the variables, it is also a systematic distortion when collecting information about exposures and disease, classification, labeling of exposure and the disease, and information bias occurs during data collection. Now, we have this type of information bias which we call misclassification bias. And misclassification bias occurs when classification of the exposure status and or of the disease status is biased, meaning the exposed or the diseased individuals are labeled as non-exposed or non-diseased or vice versa. And meaning you say that the patient is exposed, but in truth and in fact, patient is not exposed. Or patient has a disease, the truth is patient does not have the disease. So that is what we call misclassification bias, being an information bias. Misclassification can arise when there is inaccuracy in the diagnostic tests that will lead to misclassification of the disease status or procedures in the form of a questionnaire or other diagnostic procedure that will label an individual to be exposed or unexposed, his or her exposure status. Now, there are two types of misclassification bias. We have what we call the non-differential misclassification. And this arises when the instrument, a questionnaire for example, or a procedure used in the definition of the exposure status or even of the disease differ in those with the disease and in those without the disease. So again, the definition of the exposure status does not differ in those with the disease and in those without the disease. So for example, you use a non-validated questionnaire in the definition, in the classification of the exposure, or even a validated questionnaire when we measure the exposure for the disease, for those with the outcome, and for those without the disease or those without the outcome. So the definition that one uses for people who have the disease and people who don't have the disease is the same. non-validated or even a validated questionnaire. So, for example, if I want to look into the relationship between uh, anxiety and depression with willingness to know the prognosis among patients with stage 4 cancer. Okay, so we want to look into whether presence or absence of anxiety and or depression is related to willingness of patients to know the prognosis of her cancer, his or her cancer. And so we use a questionnaire, a validated questionnaire, to determine anxiety and depression in the form of HADS, the Hospital Anxiety Depression Scale, and that is a validated questionnaire. Except that some people may be labeled as having anxiety and or depression, but the truth is they don't have, or some people may be labeled as not having anxiety and depression, but the truth is they do have anxiety and depression, precisely because the HADS is a validated questionnaire. It is only used for screening, but a lot of people, investigator researchers, use that in the classification of anxiety and depression. And therefore, when you use that to look into the relationship between anxiety and depression, with the willingness to know the prognosis, willing or unwilling, because you are using the same questionnaire among those willing and unwilling, then we have a non-differential misclassification. Okay. Differential misclassification, on the other hand, arises when the instrument, a questionnaire or a procedure used in the definition of the exposure now differs in those with the disease and in those without the disease. So, example of this differential misclassification is in a case-controlled study where the ability to recall past exposure can differ among people who have the disease, the cases, and those who don't have the disease, the control. We actually call this information bias as the recall bias. Recall bias. Meaning, there is bias in the recollection of past exposure. In a case-controlled study, you recall past exposure of something. Now, among those people with the disease cases and among those people without the disease control. So, people who have the disease are more likely to recall past exposure to something. But people who don't have the disease are less likely to recall. As we said, we call this recall bias. So, for example, we want to look into whether exposure to automotive paint is related to aplastic anemia among children, for example. And then, so we have the cases as having aplastic anemia, and the control, those don't have, the people or children who don't have aplastic anemia. And then we ask the mother with children who have aplastic anemia if her child was exposed months ago to or years ago to automotive paint. But because the mother knows that her child has aplastic anemia, she will try to recollect. She will try to recall more carefully whether the child indeed had exposure to aplastic anemia. But if the mother of a child does not have aplastic anemia, and you ask that mother if that child has an exposure to aplastic anemia, to automotive paint, the mother will just say none. So people with the disease are more likely to recall past exposure than people who don't have the disease. So that's an example of a differential misclassification. The classification of exposure among the cases and among the control are different. Okay, now let's try to have some exercise. So try to classify whether this particular, I'll be giving you examples and then just tell me if this is a differential or non-differential misclassification. So faulty measuring instruments used to measure, for example, hypertension, and one uses an aneroid. So meaning this aneroid will always give hypotensive results, low blood pressure results among exposed and unexposed. So you use the same instrument. So what misclassification bias is that? Differential or non-differential? Okay. So we'll just we won't ask you to that's non-differential because same instrument, different standards in the different biochemical laboratories. So for example, we want to look into factors affecting control of DM. So and then to be able, you use, for example, hemoglobin A1C in the determination of control of DM, and then patients from different doctors, if you use many investigators, different doctors go to different laboratories, and different laboratories have different biochemical reagents that they use in the determination of hemoglobin A1C, and then there will be a misclassification of bias that will be differential. If some people go to this laboratory for this particular exposure, and then another one, this particular exposure, and then there will be a non-differential misclassification. Now, errors by clinicians in the diagnosis of the disease. Some clinicians, for example, if you get this a multi-center study, for example, and then some doctors will use for the diagnosis of H. pylori, for example. Some doctors will use the urea breath test, others will do histopathology, and then there will be a differential misclassification. Bias by investigators consciously or unconsciously reporting more favorable results for treatments that they believe in. So, if there are many investigators looking into the effect of the drug to patients, and they want consciously, they report either consciously or unconsciously report more favorable results for the treatments that they believe in. So there will be a differential misclassification. Biased reporting of symptoms by patients wishing to please doctors treating them. So they will say, for example, especially if the symptoms are quality of life, so doctors or patients would want to please their doctors by saying that they have good quality, even if the quality of life may not really be that good. So there are differences in the different patients, so there will be a differential misclassification bias. And lastly, memory lapses by subjects in a case control study asked to recall past exposure to a risk factor, which we discussed a while ago. We call this the recall bias. Okay, now how do we now control information bias? This may be reduced or even eliminated by a good study design. So, for example, in the investigators or patients reporting symptoms that for doctors, for treatments that they believe in, or for symptoms to reporting of symptoms of patients to doctors to please them. We can blind both the investigators and the subjects. We have this double blind, or even just the investigator himself if the subjects cannot be blinded, so double the single blind. So this is one way to control information bias. And of course, we need to, as much as possible, we need to use a gold standard or a reference standard in the diagnosis of the disease when we make a diagnosis of the disease. Or use a validated questionnaire, never use a non-validated questionnaire in research. Now, we go to the next type of bias, the selection bias. That's an error resulting from methods used in recruiting participants for the study and or from factors affecting the study participation. So it can result from methods that you use in the recruitment and from the factors that can affect study participation. And we have different types of selection bias, many types of selection bias. The first is non-response bias, and this occurs when there is a significant difference in the characteristics of those who respond to a survey, to a study, compared to those who don't. So there will be this is non-response bias. So for example, if you use emails to reach out to potential participants, younger individuals are less likely to open their emails. They're used to other platforms like Messenger, Viber, or what have you, than older ones. Or single males, studies show that single males are less likely to respond to surveys than the rest of the population. So that generalization, if you get people from those who responded only, and these people who respond, okay, they have different characteristics among people who don't respond, and then generalization of these results will be biased. Another type of bias, of selection bias, is what we call the incidence prevalence bias. And this is common in cross-sectional studies. They also call it the Neyman bias. Okay. The Neyman bias occurs when the very sick or the very well or both are erroneously excluded from the study. And excluding patients who have died because they are the very sick, so you exclude them because they have died, will make a condition less severe. And likewise, excluding patients who have recovered will make a condition more severe. So Neyman bias often happens when there is a significant amount of time that has passed between the exposure and the investigation in the research done. Patients who have died or recovered will erroneously be excluded from any analysis, of course, skewing the results because they are not there to begin with. Okay? So, an example of Neyman or incidence prevalence bias is study of patients hospitalized for flu will miss those who have died and those who have been discharged after recovery if you only get hospitalized patients for flu. Another selection bias is what we call the loss to follow-up bias. This occurs in many prospective cohort studies and even in a clinical trial. The true relationship between the exposure and the disease will be distorted if losses during follow-up are selective, meaning losses to follow-up are selective, non-random, with respect to both the exposure and the outcome. Again, studies show that in general, non-participation and loss, this is, well, later on we'll talk of this non-participation as the, non-response. We talked about this non-response, non-participation, and loss to follow up tend to be more pronounced among the less advantaged and the less healthy, leading to a cohort being relatively healthy or wealthy subpopulation if they are lost to follow up. And even in a clinical trial, survival and losses to follow up differ in the two treatment groups or the two exposure groups that we compare. So, for example, if you are comparing a chemotherapeutic drug that is more that has serious adverse events than chemotherapeutic drugs with less serious, there may be survival in the two, or losses to follow up between the two groups may be different, and that will lead to this loss to follow up bias. Another form of selection bias is confounding by indication, and this occurs when the indication to treatment is a confounder to the treatment outcome relationship. And this commonly occurs in observational studies of treatment effectiveness. Normally, when we look into the effectiveness or efficacy of a treatment, we use a clinical trial. But sometimes, or should I say many times, it's difficult to do a clinical trial, so we just do an observational study. So, for example, an observational study on remdesivir for COVID-19, the outcome being initiation of MECVENT, and those given remdesivir in that particular cohort observational study were those with high flow oxygen requirement, and those given the standard of care alone, so remdesivir plus standard of care, many of them, remdesivir was given to them, they had high flow nasal oxygen, whereas those given standard of care alone, few were given high flow oxygen. And so there will be differences in the baseline characteristics of the two groups, and it will appear that remdesivir, because there will be more people who will have to be initiated with MECVENT, because they are, to begin with, prognosis of these people is worse than those people given the standard of care. And so the bias will be towards the null hypothesis. So remdesivir will appear not to be effective compared to standard of care alone. Volunteer bias, this occurs when individuals who volunteer for a study differ in the relevant clinical characteristics from those who do not volunteer. And again, studies show, in general, those who volunteers are the more educated ones, and they come from higher social class than those who don't volunteer. Or if, for example, you want to look into the prevalence of diabetes mellitus, then you just get data from a community outreach program where you ask people to go to that community because we have a free FBS screening, okay, and people who will volunteer will be those people who they think are at risk of having DM, because probably they have history of DM in the family history, so they are the ones more likely to volunteer than those people who don't have history. And therefore, when you look into the prevalence of DM in that community, the prevalence will be abnormally high than it is. Okay, we have another type of bias which we call the hospital patient bias, or more commonly known as the Bergson's bias. And this Bergson's bias occurs when hospital controls are used in a case control study. So, for example, we want to look into the relationship between smoking and chronic lung disease. And in the relationship between this smoking, the exposure, and the disease, chronic lung disease, will tend to be weaker if you get controls from the hospital population than if you get controls from the community. Because people who don't have lung disease that are hospitalized have also higher proportion who are smokers, because smoking causes many diseases that can result to hospitalization. And that is why doing a case control study and getting the control in the hospital will lead to what we call Bergson's bias. In this example, the hospital controls do not represent the prevalence or the proportion of exposure, smoking in the community from which cases of chronic lung disease arise. And the exposure disease association has been distorted by this selection of hospital control. Again, as I mentioned a while ago, the relationship will tend to be weaker. And lastly, we have the healthy worker effect bias. Generally, working individuals are healthier than individuals who are not working. And the reason for this is that before an individual is admitted in a company for work, that individual has to submit first a medical certificate that he is healthy. So generally speaking, working individuals are healthier. Now, that is why when you make a study, for example, occupational exposure studies, where cases or exposed are workers, controls or non-exposed should also be workers. Otherwise, because if you get the control in the general population outside a company, the association between the exposure and the disease will tend to be biased towards the null hypothesis. Okay, so let's go to the last, the confounding. Just to refresh you, this is the first error factor, systematic error or bias. The first is information bias, the second is selection bias, and then the third is confounding. And confounding is one of the most intriguing biases that can occur in epidemiologic research. It arises when an outcome has two determinants or predictors which themselves are associated. These determinants or predictors or the independent variables are associated among themselves, and one determinant, one predictor is omitted from consideration. While information bias involves error in the measurement of a variable, confounding, on the other hand, involves error in the interpretation of what may be an accurate measurement. So there is no information bias, but the bias that we have is confounding. So let's try to define what a confounding is. That's a distortion in the estimated exposure effect that results from differences in the risk between the exposed and the unexposed. And these differences in the risk is normally in the exposed, between the exposed and the unexposed, is normally given as risk ratio or odds ratio. And the differences in the risk between the exposed and the unexposed are not due to the exposure. And that is why there is a distortion in the estimated exposure effect, in the risk ratio or in the odds ratio. Okay, now, two necessary criteria for a variable to explain the differences in the risk. We called here the differences in the risk, or the risk, so that will result to a risk ratio or odds ratio, and hence explain confounding. So what are these two criteria? The first is that a confounder, a variable is a confounder if it is a risk factor for the disease among the unexposed. Even among the unexposed, the main determinant variable, that confounder is a risk factor for the disease. So meaning the association between the confounding factor and the disease is independent of its relationship with the exposure. Because the second criterion is it must also be associated with exposure. So the confounder is also associated with exposure, and it is also associated, that's your second criterion, and then it is also associated, this confounder is also associated with the disease, the first criterion, but its association with the disease is independent of its association with exposure. So let's give a diagram for that. This is the main exposure variable, the main determinant or the main independent variable, and this is the outcome, and this is a confounder, and this confounder is associated with, is related with the outcome. And it is also related with your first criterion, and it is also related with the exposure, main exposure variable. That is your second criterion. But the relationship of this confounding to the outcome is independent of its relationship with the main independent variable, Okay, so let's give an example. So physical activity, we classify them as inactive or active, and stroke, presence or absence of stroke. Here, age, classified as young and old, is a possible confounder. So how will that happen? So let's look into this situation. So age is related to stroke. The very old, the old are more likely to have stroke than the young. So that's the first criterion, and it is also related with physical activity. The young are more likely to be active than the old. So it's also related with physical activity. Okay, but that's your first criterion. But its relationship, the second criterion, I should say, the relationship of age with stroke is independent of its relationship with physical activity. So now age has fulfilled the criteria for a confounder, and therefore we can say that age is a potential confounder. Now, how do we control confounders? Confounders can be controlled or can be done, the control of confounders can be done in either of two ways. In the design stage, meaning when you design the protocol, and in the analysis stage, meaning you already have collected data and then you will analyze. So, no longer in the design stage. Design stage during the stage of protocol making. Okay, let's first talk of control of confounder in the design stage. Restriction. The first is restriction. In my example a while ago, in the relationship between physical activity and stroke, okay, one confounder is age. Okay, if I do use restriction, I will restrict participation to the young only. So only the young will be my participants. I won't get the old. Or I will restrict participation to the study among the old. So the young will be excluded. And therefore, we have removed age as a confounder. Okay. The next is matching. Matching means I will for every active individual that is who is young, okay, get another individual active who is old. Or another for every inactive individual who is young, get another one who is old. Match it with one who is old. And therefore, when you do that, the number of people who are young, number of people who are old among the inactive or the active will be more or less the same because you have matched the two in terms of age. Okay, and that is matching. You have removed age as a confounder. And then the last is randomization. Randomization is done in a clinical trial. And we know that when we do randomization, okay, we make the characteristics of the two exposure groups, of the two treatment groups, the same, as long as the sample size is fairly large. So we make the characteristics of the two groups equal, and if the characteristics of the two groups are equal, we actually remove the confounders. Okay, so these are the ways to control for confounders in the design stage. Now, in the analysis stage, we do stratified analysis and multivariate analysis. So we stratify the analysis with regard to the confounder. Let me give you an example of a stratified analysis to control for a confounder. Suppose we want to look into whether, this is a hypothetical data on the relationship between alcoholism and lung cancer. So you will note from the data, hypothetical data, that there are more people who have lung cancer among the alcoholics compared to the non-alcoholics. So there seems to be a relationship between alcoholism and lung cancer. But a potential confounder is smoking. So smoking can be confounder in the supposed relationship between alcoholism and lung cancer, because smoking is related to lung cancer. First criterion. And it is also related to alcoholism. Those who smoke are also those people, or many people who smoke are also alcoholics than people who don't smoke. So smoking is related to alcoholism. In the association of smoking with lung cancer, the first criterion is independent of its relationship with alcoholism. So we fulfill the criteria for smoking as a confounder. So we do now stratified analysis, because We have not done, in the design stage, we have not done restriction. We didn't restrict our study among the non-smokers only. We didn't do matching. So, we're left with analysis stage. And we do stratified analysis. When we do stratified analysis, we make an analysis of the same. We make an analysis of the same relationship between alcoholism and lung cancer, but only among the smokers. Only among the smokers. We remove the non-smokers. In the analysis, you stratify analysis among the smokers. Okay, so you will note now the difference in the proportion of lung cancer among the alcoholics and the non-alcoholics has been reduced. Okay, and then we do another stratified analysis among now the non-smokers. So we have two analyses, one among of the relationship between alcoholism and lung cancer among the smokers, and another one among the non-smokers. So you will note again the difference between the two has been reduced. You see, when we don't control for confounders in the relationship, we don't control for the confounders, relationship can be seen even if there is none, so that when you do stratified analysis, the relationship will be locked. There won't be any more relationship between the two. Or it can also happen that there is no relationship when the confounder was not controlled in the relationship between two variables. But when you do stratified analysis or control for the confounder, and there will now be a relationship between the independent and the dependent variables. Or it can also happen that there is no relationship even if confounder is not controlled, and still with the control of confounders there is still no relationship, or with the relationship without the confounder and still relationship with the confounder. So anything can happen when in the relationship between the two, when we control confounders. Okay, so and then another one, controlling for confounders, will be using multivariate analysis. The concept of multivariate analysis is very much like that of a stratified analysis. But now, with stratified analysis, we add just one more variable looking into the relationship between an independent and the dependent variable. We just add one variable with, in our example, we added smoking as another variable. But with multivariate analysis, we add more than one variable. So there will be 2, 3, 4, 5, etc. variables that you control in the analysis. And I would like to just give you an idea of how multivariate analysis is done. Just the concept. Looking again into my example on the relationship between physical activity and stroke, where age is a confounder. Okay, doing a stratified analysis, we get two groups of people, one young and another old, in the relationship between physical activity and stroke. So there will be two analyses. Now, if we add another confounder, for example, hypertension, there will actually be four analyses. So meaning, we look into the relationship between physical activity and stroke among the young non-hypertensive. First, look into the same relationship among the young hypertensive. Okay, second, then we look into the same relationship among the old non-hypertensive, and lastly, we look into the same relationship among the old hypertensive. So we have four analysis when we add another variable. Then if we add still another variable, and then the analysis becomes complicated, but of course, statistical software can easily do multivariate analysis, not the way that I explained it to you. I just gave you the concept of multivariate analysis. Okay, so this should be the last. So again, just to refresh you, two error factors that will threaten the validity of the conclusion: the systematic error, which we call the bias, and systematic error or bias has three: information, selection bias, and then the confounding. And then the second error factor is the random error. And we told you a while ago that with random error, that's not really a problem because that's inherent in all research. That's the difference between the estimate and the parameter. We only want really to make an estimate of the parameter. The parameter is in the general population or in the target population. But we only get a sample, and there will always be a difference when you get a sample, compare it to the total population. We also call this the chance error. So this is an example of a random error. So there is a difference in the what you call this, in the number of lung cancer among the alcoholics compared to the non-alcoholics. And if you calculate for the odds ratio is greater than 1, and that means that alcoholism is a risk factor to lung cancer, except that the relationship may not be statistically significant. The reason for the supposed relationship is just due to a chance error or a random error. So this is my last, and these are my references. Okay, and so thank you.